Recording in progress.
Good morning, everybody. We are glad you joined us. I'm Cassie Sauer at the Washington State Hospital Association. We won't start until we get everyone into the meeting and granting the recording privileges. So just give us a few minutes. Again, for folks who are just joining, good morning. I'm Cassie Sauer with the Washington State Hospital Association. And as always, we are going through and granting recording privileges to all the members of the media. That is underway right now. We'll start in just a moment. Thanks a lot for being here. Again, for folks who are just joining, we're going through the list and giving everyone recording privileges, and I think we're nearly done, and we'll start as soon as that's done. Thanks a lot for joining us today. So Mita, Ashley, Cindy, just let me know when you're done.
This is Mita. I believe I am done. Ashley, what about you?
Hi there. Yep, I think we are good to go.
Okay, great. Thank you both very much. Appreciate it. Okay, welcome everyone. I'm Cassie Sauer, and I'm the CEO of the Washington State Hospital Association. We're very glad that you've joined us today. We have, unfortunately, sobering news to share with you today. I think we said in our last media briefing that we had suspended or canceled or delayed the media briefings because there wasn't that much news to report. We did one about, I think, 10 days ago with a lot of news to report. We have even more news to report today. We would like very much to not be having to have COVID-related media briefings, but unfortunately, that's where we are today. Ashley, can you take down the slide that's still showing, please? Thank you. And I'll start by telling you who's on with us today. We've got a very nice set of panelists here from across the state with really interesting backgrounds. So we're going to hear from Mark Taylor, who's the Director of Operations at the Washington Medical Coordination Center. That's housed at Harborview, and it's the organization that's coordinating transfers across the state for all hospitals, and has been just an incredible resource for us throughout the pandemic. We'll hear from Dr. Danielle Zaire, who is the Pediatric Infectious Disease Chief at Seattle Children's. There's been a lot of interest in how this current wave of COVID is affecting kids, especially with schools about to start. Dr. George Diaz, who's the infectious disease leader at Providence Everett Regional Medical Center, is also joining us. Dr. Diaz can share the perspective about what's happening with adults and the really alarming rise of COVID that we're seeing around the state. And finally, Shane McGuire, who's the CEO of Columbia County Health System in Dayton, will provide the rural perspective. The rural hospitals have been particularly stressed in receiving patients who are very, very ill and looking to find places for them to go in a hospital system that's quite crowded right now. So we'll get to the panelists in just a few minutes. I'll start with some opening remarks. First, hospitals are still really, really full across the state. I want to have an important caveat of that. If you need hospital care, go to the hospital. You know, if you feel like you're having chest pain or a stroke, or you've had some sort of trauma, you should still go to the hospital. They will care for you, but they are really full. We want people who don't need hospital care to not come to the hospital. So ways you cannot need hospital care. The number one way you cannot need hospital care is to get your vaccination, your COVID vaccination. We do not want to see more COVID patients in the hospital. People are very, very ill. So stay out of the hospital by getting your COVID vaccination. Wear your mask. We are really pleased the governor has reissued the indoor mask order. I know it's challenging for people to figure out. It feels like, you know, back and forth, but that's what this disease is doing. It's not the governor being wishy-washy, it's the disease being wily. The disease is really challenging and changes all the time. And so it's a very appropriate response to the current disease state that we're in. We really urge people to seek their preventive care. If you've got a chronic condition, if you're managing diabetes or congestive heart failure, to be sure that you're connecting with your primary care provider or your specialist, getting the care that you need that will keep you out of the hospital. And finally, be careful. I think this is a time we've seen a lot of trauma. I think the heat and summertime and people's desire to be out doing things, like be careful on your bike. Don't climb a ladder. You know, there's a lot of trauma is people falling off ladders. Just stay off your ladder. Leave the leaves in the gutter for now. Really just, you know, wear your life jackets. Be careful with yourself. Be careful with your family so you don't need trauma care. So those are some things, some tips we have about what the public can really do to keep themselves out of the hospital. But again, if you need hospital care, go to the hospital. We don't want you to get sicker. COVID hospitalizations are at the highest they have ever been in Washington state, which is terrible news to report. So if you recall, about a couple of months ago, we were saying the hospitalizations were about 300 to 350, holding steady. They stayed at that level for weeks. It felt like that was when it felt like we were going to be able to return to normal. We weren't seeing a big uptick. The highest we ever were was in December with about 1,100 patients. And right now we are at 1,240 hospitalized patients across Washington state as of this morning. There may be some more data that comes in. I think that number would only go up. That number has been doubling about every 2 weeks. It may be slowing down a tiny bit. It looks like in the last 2 or 3 days, there's a slight slowing. We don't know if that's a trend or a blip. I hope it's a trend, but it is a huge concern and leads back to my first point about get your vaccine. People who are coming into the hospitals are really sick. Some people get really, really a lot sicker faster. I think folks have been probably reading the news stories about people who have died, who are leaving their children behind, you know, really tragic stories. So disease is not conquered. Please make sure you're doing everything you can to protect yourself. Hospitals are also stressed because of other circumstances. As I mentioned, it's summertime. People do more things that lead to trauma. And so the ladder climbing is something we want folks to avoid, but, you know, all kinds of things. There's drowning incidents and gunshots and, you know, cut yourself with your power, I can't think of the word, the hedge trimmers, you know, all that kind of stuff. So we're seeing a lot more of that, plus heat, plus smoke. All those things are contributing to the hospital burden. And also delayed care from prior times. People were worried about coming to the hospital for care or thought there wasn't room for them, which is why we really want to emphasize the point that there is room in the hospital if you need severe acute care. So we are working on ways to decompress the hospitals right now. And the biggest action that we are working on is getting out of the hospital people who no longer need medical care. These are patients who are alternately called long length of stay patients or difficult to discharge patients. Some of them aren't there for very long. Long length of stay could be 3 days post their medical care. Sometimes it could be 6 months or a year post their medical care. A lot of it's kind of in the middle. But their medical care has been completed and they need a place to go. They need their families to be able to take them. They need to go to nursing home. They need to go to rehab hospital. They need to go to adult family home, a psychiatric hospital. Some kind of care needs to be set up for them. So we've been working really closely with the state and are very pleased with the actions they're taking and want to emphasize the need for acceleration and huge focus on these actions. But the Department of Social and Health Services is working to move out the folks who need long-term services and supports. The Healthcare Authority is working to move out patients who are on Medicaid. The state's Medicaid managed care plans have been instructed by the state to respond to requests for transfer within 24 hours, including on the weekends from hospitals. That typically is a process that can take multiple days. The Office of Financial Management, which is basically the state's budget office, has been extraordinary in funding some of the initiatives that will help move patients out, providing payment incentives to long-term care, adult family homes. So we really appreciate their leadership. The governor's office and the Healthcare Authority have played a really important coordinating role in all this, moving all the state agencies in the right directions to move patients out. So that is work that's critical. We will have plenty of capacity if we can move those patients out. So that's really important to know. We also are working on giving resources to hospitals. We, this morning on a call with rural hospitals, talked about the National Emergency Telecritical Care Network, which is a federal resource that provides teleconsult to hospitals that are providing critical care to patients that is beyond their typical scope. And we're going to be doing demonstrations of that system today, a couple of them actually for our rural hospitals, really encouraging folks to sign up and start using that. And then we're working with the state on its recent very urgent call up of volunteers for volunteers to work in clinical settings, including hospitals, also long-term care settings, really being able to extend the staff that are working there. The last comment I would make is that we are seeing a blood supply challenge right now. And so we often get questions, we've said this before, from the public about how can I help? And people often say, can I send pizza? Can I send cookies to the hospital? And those are lovely actions. Even more important, first, number one, get your vaccine. Number two, wear your mask. Number three, consider being a blood donor. This is a great time to donate blood and to really shore up the blood supply so we can make sure that that's not a secondary crisis that's happening. Really encourage especially new donors to join the Donor Force. Bloodworks is a great organization that can help you get connected. The Red Cross, really hope that folks will take that help. So with that, I'm going to turn it over to Mark Taylor to give us more in-depth situation report and what the WMCC is working on these days. Thank you, Mark.
Well, thank you, Cassie, and yeah, thanks for the opportunity to chat about this a little bit. I did put together a few slides just to frame the discussion, if we were able to pull those up. Perfect. Thank you. I wanted to give just a little bit of background on the Washington Medical Coordination Center. As Cassie mentioned, it was really created with the idea in mind that we would balance the impact from the COVID pandemic through Washington State hospitals. We wanted exclusively really to avoid that situation where a single isolated facility in an area that was suffering additional impact from COVID may become overrun from caring for those patients, and especially if there is capacity available in other hospitals, either in that area or throughout the state. And so the idea being, could we set up a center that would leverage that capability and capacity that exists in other areas, balance that distribution, transfer patients maybe a little bit farther than they would have initially been presented to than the facility that they would have presented to, but ensure that the census in that facility remained at a level that they were able to manage, and that and they never had to enter a situation where they had to make those horrendous choices that we see on the news sometimes from other states. We do this a lot in hospitals in response to mass casualty incidents, and so this is not an unusual circumstance, but it is I think becoming a much more common approach to leveraging capability and capacity in states or regions to ensure that we avoid any situation where a facility is unable to manage the patients they have to take care of. If you could go to the next slide. So the workflow around the Washington Medical Coordination Center is this. We ask that facilities, when they find themselves either with a patient that is exceeding their capability, meaning that the patient presents with a condition or a circumstance that they don't have services available. So you can imagine this comes up very frequently in our rural and critical access hospitals. If that's the case, and they attempt to find a resource facility that can accept their patient, and that resource facility, for whatever reason, occupancy or availability is unable to support them, if in that circumstance, go ahead and call the Washington Medical Coordination Center. We are available then 24/7 to assist them in finding a facility that will have that capability in terms of the services available and has capacity to admit that patient and support the overall patient care that they need. So in essence, a call to the Washington Medical Coordination Center becomes sort of a surrogate for or an indicator of stress in the hospital system. And I'll talk about this in just a little bit, so I wanted to just frame that discussion. But you'll see there on the bottom of the screen multiple instances where we have seen states throughout the country that have been telling stories of hospitals that do have a large volume of patients that have simply become overrun with the numbers of patients that they have to take care of, and have gone to extraordinary measures to accomplish that care. In essence, Washington State's leveraging this capability has prevented us from ever having to entertain this option. All hospitals sort of fill at the same time, making sure that there are no isolated pockets of facilities that can't provide the care that we all want to make sure our patients receive. Next slide, please. Cassie mentioned this, the significant increases that we're seeing in hospital occupancy. And I think I just want to kind of bring us back a little bit regarding how this occurred and how this developed, because one of the things that we noticed with our hospital occupancy numbers is that as the COVID numbers declined, we started to see patients who had maybe delayed care, maybe have been putting off preventative care, started to return to the hospitals. We started to see numbers of patients in hospitals increase, even though hospital numbers of COVID patients were declining in the spring. So this really became apparent at the end of the spring surge, when which would have put us in probably the second week or so of May, and I'll have a graph that shows this. COVID numbers decreased, but hospital occupancy became very high, and at that time, as hospitals scaled up and started to approach 90, 95, 100% censuses throughout the state, we started to then realize some of these staffing challenges that you're all hearing about. It occurred certainly significantly within our hospitals, but also throughout the healthcare continuum, including long-term care. And that has resulted, as long-term care facilities then became unable to accept patients, we started to see more and more of those patients retained within our acute care hospitals. And this also added to some of the longer length of stay that we see, added to the higher census that we see. And then on top of that, around the 1st of July, we started escalating the COVID numbers and the COVID hospitalizations throughout the state. Next slide, please. So as I was talking about earlier, with the call volume being a surrogate for our as an indicator of the stress in the hospital system, we know that we had a surge that occurred around Thanksgiving of COVID patients. Yeah, represented there, and we see that in our call volume to the WMCC, which is represented there by the bars in November and December. You'll notice that the bars there are almost exclusively related to COVID patients there, which is represented here in the orange portion of the bars. We saw the numbers of calls escalating during that time frame, then slightly decreasing through as that post-Thanksgiving surge waned in terms of COVID numbers, and then picking again up in the spring COVID surge, but you'll see dramatically increasing further with the non-COVID calls that we received into June, July, and now first part of August, where we are again starting to see more and more COVID-related impact from our calls. But the overarching theme is that our call volume has escalated primarily from non-COVID related calls. This is just an indication, I think, of the general strain that we're seeing in hospitals related to occupancy, primarily driven by very high non-COVID census on top of now an increasing number of COVID patients. Next slide, please. And this again reinforced just by the numbers of COVID patients in our hospitals throughout the state. This data is from WA Health, showing hospitalizations. This is the number of patients in Washington State hospitals being treated as inpatients daily. And starting again in for that post-Thanksgiving surge through December, we see what's happening there in spring through the April and May timeframe. And now, as Kathy mentioned, we are rapidly, actually have now exceeded the highest number of patients that we have ever had in Washington State hospitals being treated for COVID here in the second week of August. As was mentioned, we are hopefully over the last couple of days starting to see a decrease, or I guess it's not really a decrease overall, it's a slowing in the increased numbers of COVID patients being admitted. So hopefully this will decline a little bit over the next few days, but you can see that layering on another 1,200 patients into Washington State hospitals on top of already very high occupancy can be very challenging for the system. Next slide, please. And then just reinforcing that statement regarding the stress that we see or the call volume being an indicator of stress. This is just showing our total number of calls there in blue, and again, non-COVID being represented there by the orange bar or the orange line, and in gray at the bottom, the rising COVID numbers of calls coming into the Washington Medical Coordination Center. I think that may be the last slide that I have in place, but as far as things that we can do from here going forward, I couldn't reinforce more what Cassie was saying earlier. Hospitals are at extremely high occupancy at this point in time. Care is being provided. They are able to accommodate the numbers of patients that are coming into the system, but it is extremely important that we do what we can to minimize the COVID impact to this high occupancy. So things like vaccination, things like social distancing, mask wearing become extremely important. I couldn't emphasize enough the importance around this is trauma season here at Harborview. This is our busiest time of the year. So anything we can do regarding preventing injury is extremely important, not only for minimizing the total number of patients in our hospitals, but also, as Cassie mentioned, it's extremely important to remember that we are currently in the midst of a blood shortage, driven largely by reduced numbers of donors, as people again have sort of gotten that out of their normal routine in terms of blood donation. So reach out to Bloodworks Northwest, American Red Cross, other agencies, become a donor, be careful, be social distanced, wear your mask. All of those things become extreme priorities in terms of impacts that we can all make to hopefully create a little bit of capacity in the system. Thank you.
Thank you so much, as always, Mark. Thanks for your amazing leadership in this time. Really appreciate it. Dr. Zaire, we'd love to hear from you about what you're seeing for kids.
Sure, thanks, Cassie. Seattle Children's is seeing an exceptionally high number of patients currently. Our hospital census is approximately 100% of staffable beds, and our urgent care clinics and emergency department are also near 100% occupancy. Patients with COVID-19 make up a small proportion of our overall census, about 1 to 3% of our total patients. And our maximum number of patients with COVID-19 has been 10 to 11 patients at a maximum over time. And that's what we experienced last winter and are now experiencing again. The patients this time around appear to be sicker than during previous waves. They're requiring higher level of care and support, such as intubation and mechanical ventilation and ECMO in many cases, or mechanical ventilation in a number of cases and ECMO in a few cases. Most of the patients who have required hospitalization due to COVID-19 are unvaccinated teenagers, and many are previously healthy, with obesity being the only risk factor that they have. And due to the unusually high number of patients overall, our staffing resources are stretched across the hospital, and we're working hard to triage patients and expand our capacity to care for as many children as possible. And we are committed to providing every patient and family with the best care possible. Families that are coming for appointments should expect longer wait times than normal. Our emergency department is triaging patients as usual to see the most urgently sick kids first. So I think the bottom line is if your child is having a medical emergency, please do come to the emergency department. If you have a scheduled appointment with us, please do keep it. Our urgent care has very limited number of walk-in visits available. And in some cases with walk-ins, we're having to redirect patients elsewhere. So if you need urgent care, we recommend scheduling an appointment to make sure you have that appointment secured. And in non-emergency situations, we would ask people to please contact your primary care provider to find out what the best course of action is. And as stated by others today, people can help by getting vaccinated as soon as they possibly can, and by making healthy choices around masking, avoiding crowds, social distancing whenever possible. And hopefully we can maintain the capacity that we have. Thanks.
Thank you so much, Dr. Zara. I know I have 3 children, 2 of whom are vaccine eligible and fully vaccinated. 1 of whom is not yet by age. And it's nerve-wracking, I know, for parents to be navigating this vaccinated, unvaccinated situation.
Yes.
Yeah. Dr. Diaz, I know Providence Everett has been at a place of stress. I'd love to hear what you're seeing, and also how the difficult to discharge issue is affecting your capacity.
Yeah, thank you for having us today. We are under stress up in Everett. We have a large hospital, about 600 beds. Our inpatient census of COVID patients is approaching the peak that we saw earlier this year over the winter. And the vast majority of the patients that are coming in now are unvaccinated. About 5%, maybe up to 10% of the patients in the hospital have been vaccinated, but are vulnerable patients. These are patients with a history of cancer, leukemias, transplants, who did the right thing and got vaccinated, but were exposed in the community and now are in the hospital, in the ICU, fighting for their lives. These patients did the right thing and got vaccinated, but despite that, were exposed by primarily people that are unvaccinated. And people that are vaccinated are creating a risk for everybody else. We know that these variants that are out there now, the Delta variant, for example, is much more contagious, possibly as contagious as chickenpox. And despite our community having a reasonably high vaccination rate, the 30% of people out there that are unvaccinated are driving the development of variants. They're the people that are coming into the hospital. They're the ones that are exposing our vulnerable patients to this disease as well. So the biggest thing we really encourage is everyone to get vaccinated. Yesterday at Providence Everett, there was a protest outside our hospital by anti-vaccine folks that were arguing against vaccination and were arguing against the mandates that the governor had announced the other day. I'd like to say that at Providence, we strongly support the position of the governor and public health, Washington State Hospital Association, in terms of getting everyone vaccinated. This is really the only way out of the pandemic. The unvaccinated are applying a lot of pressure to our hospital, just based on people coming in. And not only are the numbers high, the types of patients that are coming in the hospital are different than before. Early in the pandemic, we were seeing older patients, frail patients coming into our ICUs. Now we're seeing a much larger number of people that are ages 30 to 39 that are becoming seriously ill, admitted and in our ICU, which is a fairly dramatic change in this pandemic for us that we're seeing. The stress is coming from several places. Firstly, the volumes that are coming into our ED are much higher with COVID. We have been providing treatments with monoclonal antibodies or IEDs, which helps. But we're also have, as mentioned before, pre-existing patients in the hospital that we simply can't get out of the hospital. As of yesterday, we had over 70 patients in the hospital who were ready for discharge and had nowhere to go. This provides and causes additional stress to our hospital and our staff. And our staff is frankly frustrated and about what's going on now. They can look out the window and see that the people protesting against vaccines outside can't see what's happening inside the building, which is very sick people on oxygen in the ICU. And it's frustrating to know that there's a large proportion of people in our community that argue against vaccines. We want people to know that the vaccines work, they're safe and effective, and they will prevent much of what's going on now in our hospital. We've had a lot of staff turnover, not only in Everett, but all the other Providence hospitals. And these are staff members that are frankly burned out and either leave the profession or go somewhere else to work. And this is a direct result of the stress that healthcare providers are experiencing on the front lines. And so this is all making things difficult. And as we move forward with trying to manage these volumes, we have seen some of our hospitals have to postpone non-emergent surgical procedures that affects those people that are waiting for procedures they need to have done. So the choices of part of our population to not vaccinate themselves are affecting the most vulnerable in our community that may not respond very well to vaccines, and those people that need care for other reasons that also have their care postponed. So we would strongly urge our entire community to please go get vaccinated as soon as possible. Thank you.
Thank you, Dr. Diaz. That's really sobering, especially, I mean, for everyone, but especially about the folks who have some sort of or immunocompromised through cancer, leukemia, and they've been exposed by someone who's unvaccinated. They got vaccinated and have been exposed, and now they're very sick. It's all tragic. That's very tragic to hear. So I think that's another really important point for people to hear, to protect those in our community who are struggling with some other sort of disease. You getting your vaccine protects others. There are breakthrough infections. That is true of COVID, but in most cases, except for if you have some sort of underlying immunocompromising disease, you're going to be protected from hospitalization or death by the vaccine. So it's really the unvaccinated folks who are driving this epidemic. And as Dr. Diaz noted, spinning off variants. We don't know what variants are coming next, but every host gives a chance for the virus to mutate. And it's very, very worrisome about the future. Shane, let's hear from you about how the rural perspective, what you're seeing.
Yeah, context is everything in rural. Most nights we have 3 staff nurses. If one nurse calls off, effectively 33% of our staffing is missing from that shift. Normally we have 5 ERs average on a day. We float staff between our med surg floor and ER. Yesterday we had 13 ERs, which puts a tremendous amount of strain on teams. I got to say, Mark and his folks have been essential. We've called the center. We're one of the ones that have called this center quite frequently. We started Monday night with a couple of patients that came in at 8 p.m. Monday night, 10 a.m. the next morning, they were still here. One of those patients was a stroke patient. We do not have surgical intervention. We do not have cardiac abilities. We don't have neurology. Most of the support we get is remote. We try to stabilize and ship. Shipping's becoming increasingly difficult. We're having to go farther and farther. It's tying up staff time when you've got critically sick patients. The patients become one-on-one. Again, in the context of having 3 nurses on the floor, 1 nurse tied up with 1 patient, sucks resources away from the other areas that we need it. And staffing is an incredible challenge. I think in the industry, we are seeing people leave the industry. We have a number of contract travel nurses. They're fantastic. I applaud them for taking contracts in rural, but getting them onboarded and functionally working is a challenge. Some of them are coming from large urban centers and are used to having lots of support structure around them, and here that's often not the case. 1 provider, 1 doctor, 1 mid-level may be on call covering the entire hospital at night. And so we've got a lot of staffing challenges. I gotta say that COVID, how it impacts rural, we are the people that do the contact screening. So public health does the tracing, but they send people to us to actually do the screening and result. We've had 297 screens, active screens in the last 18 days, 47 of those are positive. That all takes time and resources away. We have to pull nurses off the floor to put on PPE, go outside and screen. And so we're pulling nurses away from sick patients to go out and screen patients who are unvaccinated and maybe transmitting throughout the community. Even the infusions, I mean, I'm thankful for them. They are effective, but they take time and resources, again, away from others when you're having to manage that infusion on the floor. And the number of sick people, the number of sick cases in the ER is tremendous. Cardiac events, stroke events, it is, from our perspective, from sort of lack of seeking care, uncontrolled blood pressure, not working with their primary care providers and then getting in crisis. We've been able to sustain, but you know, we're months and months into this, and staff are drained and staff are tired, and you know, staff morale is challenging to maintain, and call-offs are happening. So from a rural context, you know, even one nurse not being available or one CNA not being available on the floor could be 25% of the workforce on a night or something of that nature. And so it's incredibly challenging. The sicker patients are challenging as well. We sort of got used to being able to make a phone call and have people receive our patients, and those beds aren't available right now. And so we're being stretched a little bit in our skill sets. We have 2 respiratory therapists. They're on site almost all the time, husband and wife team, really. We normally don't have our T 24 hours a day, but in this case, we've had to keep them cycling through because of how sick some of these patients are. So I echo everything everybody said about vaccination. For us, the story really has been the higher acuity patients that are not necessarily COVID patients, but then we've got this extra burden of COVID tracing and COVID response in the community that's really tapping us out.
Thank you, Shane. So this has been a very sobering series of presentations. We hope that it really emphasizes the severity of where we are right now, the necessity for vaccination, and the healthcare workers are feeling that I am hearing a level of frustration with the patients who have not gotten vaccinated, who are coming in really sick, that I don't feel like I've ever heard in all my time at the hospital association. You know, hospitals treat people who fall off ladders, as I've said before, don't wear their helmets when they ride their motorcycles, you know, have drug overdoses, you know, engage in behaviors that some people might look at as, you know, sort of they brought it upon themselves. That, however, I think that treatment that's sort of expected, and people treat those folks very, very compassionately with a lot of empathy. The frustration right now is that there's this feeling that your behavior not getting vaccinated is bringing risk to me, to my family, to others in the community, to my cancer patients, you know, that people really recognize that that choice has spiraling impacts throughout the community. So we really just want to emphasize that. So I think we're open for questions. Okay, how hard is it for hospitals to get travelers and staff right now? Is staffing and patients who can't be released really the 2 main capacity issues statewide? Yes, those are the 2 main capacity issues, getting enough staff and patients who can't be released. They're intertwined as well, because if you think about a patient who has dementia in a hospital, which is an unlocked ward, you know, it's the hospitals, you can come and go. In a nursing home memory care, a nursing home memory care unit, they're going to have it set up to take care of people with dementia and have a lot of safeguards in place. But in a hospital, you probably have to put a staff person with that patient with dementia all the time to be sure they don't wander out. So that they really are very much intertwined. It is hard for hospitals to get travelers and staff right now. As we've mentioned, people are feeling really frustrated by having to care for COVID patients who are unvaccinated. Anyone else want to comment on those 2 questions?
I mean, staffing in rural is always challenging. A lot of the contract nurses work in more urban centers, and so getting contract nurses to pick up rural contracts has always been difficult. We had a position open for almost 2 years in our nursing home, to echo what you were saying about nursing home staffing, Cassie. So I can definitely say that this has not made anything easier on us, and we're having to compete and bid for staff. We frequently will throw out a number and they'll say that's not good enough, that's not going to get you a nurse, you're going to have to go higher per hour, which is, you know, a financial strain on us.
And the next question is it correct that the surge is different for hospitals because everyone is surging at once? Yes. Hospitals all around the state are surging at once, as are all the hospitals around the country. So that's really important. Like before, you had regions of the country that were under stress and others that were not. And so staff could move, those traveler staff could move around the country, and there was, now everybody needs staff. And the last question here is, how far away are we from crisis standards of care? Our hospitals are meeting very regularly with each other to reaffirm their commitment that no individual hospital will go into crisis standards, communicating about what space we've got, working to level load, canceling procedures that are really vital. People who really need these procedures done, they're having their procedures canceled. So all those mechanisms are in place to avoid crisis standards. Steve, I see your hand is up.
Yeah, and my question kind of piggybacks on the one that was just asked, but just to be frank, and I don't know who wants to answer this, but how concerned are you about the current strain on the system? I mean, we have heard the situations in other states where hospitals are so full that decisions are having to be made about, you know, potentially not admitting a patient who needs some care. And some people are saying, you know, people will die because of this. And it sort of sounds like in most or many cases here, we're not there yet, but are we going to get there if the trends continue? Like, how much of a concern is the current situation here in Washington right now?
The current situation is very grave. I think it's a huge, which is why we're really asking for the public's help. The state's help in helping us move out difficult to discharge patients, and the public's help in not needing hospital care. Again, if you need hospital care, get hospital care. We do not want you to have a stroke and die at home, for sure. But do things that keep you from needing hospital care. Really important things. Vaccination, top of the list. Our state's hospitals, I think, are incredibly cooperative. You've seen that throughout the pandemic. Earlier in the pandemic, there were hospitals in New York and Texas and California that were overrun when they had neighboring hospitals that were not. That is not the case here. We have a written agreement among all of our hospital leaders to work together to ensure that no individual hospital goes into crisis standards. As Mark described, it's kind of going up. Everybody's going up together and level loading and canceling things and reaching the same points. Steve, I mean, I'm really worried about where it could go. However, moving out those difficult to discharge patients is job number one. Us reaching crisis standards where we're not treating people with acute medical needs because we're holding people who don't need hospital care would be completely unconscionable. So that we can create capacity by moving those people quickly. We really appreciate the state's efforts on this. We want those efforts to be accelerated, emphasized. Weekends, Labor Day, like keep it going, keep it going. We're starting to see the positive results of that. We want it to move fast.
Cassie, if I can ask a follow-up really quick, just citing some of the reporting from the Seattle Times yesterday, who I believe talked about just some of the staffing concerns in some of those outpatient facilities with nursing homes, long-term care facilities. Is that a concern when we're trying to shift many of those patients to those facilities and maybe they won't have a place to go just because they're dealing with staffing shortages right now? Yeah,
that is a concern. And that's part of why we've been advocating with the state for increased payments to nursing homes so that they can hire more staff and pay the staff that they've got more. And the Office of Financial Management has been very responsive in providing bonus payments for admissions and add-on payments and setting a better rate at the outset for these patients. But yes, it's definitely like, where can you go? Some of it's family response. We've got folks in the hospital who could go home to their families. Their families can be slow to come and get them. So really encourage people to move fast on that. If you can bring your loved one home from the hospital, do it. It's a whole complex set of issues. And Steve, I also want to say to your prior question that if we did not have this level of cooperation among our hospitals, we absolutely would be seeing more people dying who need care right now, because we would have hospitals that are overrun, other hospitals that have room.
Can I jump in with a question? This is Glenn Farley with King TV.
Yeah,
One
hi, Glenn.
of your staff members has a person, a relative in another state who just suffered a stroke. So she falls into this category that we've been talking about that are the bulk of these patients. In this case, this is another state, another hospital. I don't know what the hospital is, but it does raise an interesting question. She was in the ICU. She was getting better. They kept her in the ICU rather than moving her off to another room because the concern was that ICU bed may not be available to go back to if her condition slipped backwards. Are we having anything like that? Are we under that kind of pressure here? Is that even something you'd consider?
Dr. Diaz, will you want to take this?
Oh, I wanted to comment regarding the prior comment about nursing homes. So, as I mentioned, we had in Everett over 70 people that are awaiting discharge from our hospital. They're ready to go. That causes a lot of stress. Within Snohomish County, we have less skilled nursing beds in our county than we did 10 years ago. It's very difficult to make a business model out of a skilled nursing facility. The payments are generally so low that it's hard for them to break even or even to stay open. And so we've lost beds over the past 10 years in Snohomish County. This is a huge problem for our community, not to have adequate beds in skilled facilities to be able to send our patients to. So this is something we welcome relief from the state and the Health Association.
And Dr. Diaz, did you hear the question about, are we holding people in ICU beds because if we move them out, they might not get a bed again? I haven't heard that.
No, thankfully not. Most patients that thankfully recover in the ICU and are able to go to a regular hospital bed generally don't require readmission to the ICU. And thankfully, to this point, we've not had issues with access to ventilators or ICU beds. And to the prior comment about capacity, although we're running very high, thankfully we're not seeing what's happening in the south and central part of the country. I have friends in Oklahoma and other states where they're transferring patients out of state looking for beds. And thankfully, I have not heard of that happening here in Washington State. One of my colleagues, Dr. Frank Rito at Overlake, did accept someone from Portland the other day. So we are seeing an occasional transfer from out of state to one of our local hospitals, but thankfully it hasn't happened the other direction. But as we are not yet at the peak, we're certainly in a position where that could become an issue.
Thank you.
Cassie, I might be able to add a little bit of something though that's important to regarding that question. Hospitals are as you mentioned, hospitals are extremely high, have an extremely high occupancy. And as a result, hospitals do leverage all the space that they have available. In that sense, if, for instance, the numbers of acute care patients in a given facility are extremely high, they may, quote unquote, board patients in an ICU bed that are of acute care status, because it is in fact a physical bed, a physical space that exists in the hospital and capable of taking care of that patient. So for that reason, even though the patient is no longer meeting ICU criteria, they will likely remain in the ICU bed because there is not capacity available in the acute care area of the hospital to accommodate that patient's need. And that is a pretty widespread and common strategy that hospitals utilize to accommodate the additional numbers of patients that are existing throughout. That level of that decision-making process is in some ways an indication of the strategies that hospitals are taking to accommodate this extra number of patients that we all have. And to your point regarding long-term care, if we were able to free up those beds of patients that don't need to be in acute care hospitals, not only do we have not only do we potentially receive ideal or better strategies for care, as you mentioned regarding the patients who could potentially go to a memory care facility, but this creates significant numbers, hundreds have been identified, significant numbers of patients or beds that are occupied by patients that no longer need this this level of care in our hospitals. I know, speaking from Harborview personally, here there are roughly 80 patients that could be discharged to long-term care should that capacity become available. And we, again, as you mentioned, we very much appreciate the work that the state is doing now to promote that activity, being able to move those patients out to more appropriate care facilities to leverage a little bit of additional capacity so we don't have to make some of those surge choices.
Thanks, Mark. Steve Kiggins, you've got your hand up.
Hello, everyone. Thanks so much for making time for all of us and making time for our questions. I've got a couple here, and one is kind of off the wall, and I'm not sure it will be able to be answered here, but we'll give it a whirl. I'll start with we're hearing concern in just the general community about folks who might be on an organ transplant list, and if they're discovered that they are not or do not plan to receive a vaccination, they're being removed from that list. Is that something that is familiar or even within the realm of possibility? And then the second question has to do with wondering if you can say whether or not you're getting any guidance on efforts for booster shots, and if that's already down the pipeline fast enough that if you're able to determine when and where they might be available in Puget Sound region. Thanks so much.
Thank you. As I understand the booster shots, please correct me, folks, if I'm wrong. They're going to start September 20th, again, focusing on hospital and healthcare staff, top of the list as they were the last time around, and then rolling out through the general population over time. Is that, Dr. Diaz, is that what you understand as well?
Yeah, actually, last week the CDC announced that we would start with boosters for moderately or severely immunocompromised patients. So we're already working on doing that, identifying these patients and getting them their booster shots. And we anticipate that booster shots will become more generally available around the 20th of September. With an expected booster to be done 8 months after the second dose. So we anticipate that coming down, and we would encourage folks to get their boosters as soon as they're available as well.
Thank you. And on the transplant issue, transplant candidates are evaluated for a wide variety of readiness for transplants. Organs are in such short supply, and the waiting lists are so long that you want to make sure the person that you're giving a transplant to is fully ready for that organ and has the greatest chance of success. And receiving a transplant makes you very immunocompromised because you have to have anti-rejection drugs that really can affect your immune system. So not being protected against COVID would create, I believe, a huge risk of failure of the organ transplant. Anybody else want to comment on that? Yeah, I think it's our responsibility to safeguard organs and to give them to the most likely successful recipient. Shane, you did get a few questions about I saw you answered one in the chat, but are rural hospitals receiving lower acuity patients from larger hospitals, or are you? My sense is that the capacity is not really there any longer, but correct me if I'm wrong. And then, how are you taking care of COVID patients?
Yeah, I mean, we are able to treat COVID patients that respond and are stable and are responsive to the drugs that we now use to treat them. It becomes, if they have multiple comorbidities or high risk, we tend to want to ship them to a place that has ICU capacity, full-time RT, that type of thing. But it's not unusual for us to have hospitalized COVID patients in the facility. We do take and are taking patients from the larger urban centers. It's interesting, the patients still get a choice. And what we hear sometimes is, I don't want to go to Dayton because it's 2 hours away, or it's far from my support structure, or something of that nature. And so they're almost electing to stay in a bed that they could transfer out of, but they don't necessarily want to come that far. And so, I don't really have a good answer for that, because I believe that people need to be where their support systems are, but that functionally ties up that bed that they don't need to be in.
Thank you. Another question is, are elective medical procedures being postponed to lighten the load on hospitals? Absolutely. And I want to be clear about what elective means. We say the word elective and people hear facelift. and that is not correct. Elective could be replacement of your heart valve. It could be removal of cancerous tumor. Elective is as opposed to urgent or emergency, where you've come into the emergency room and you've suffered a trauma and you need surgery right away, or you'll be dead or disabled if you don't receive that procedure. So there's a ton of stuff being postponed right now. Maybe Mark or Dr. Diaz, you may have a particular window into what kinds of things are being postponed across the state, but it's really serious care that's getting postponed right now.
Yeah, hospitals have started to scale back elective procedures several weeks ago, actually, as we started to see more and more numbers of patients accumulate in the facilities, and the strategies that they are taking at this point in time, as you mentioned, Cassie, are any patient that's coming through or has a planned procedure in place that will occupy a bed. So if you're coming in for a procedure that can be accomplished as an outpatient, those frequently are continuing. But if they're going to occupy a bed after the surgical procedure and a delay of 90 days or more would not cause impairment, then those have been canceled. Those have been scrubbed. At some point, they will start to ramp back that delay period. So you can imagine if a physician in best judgment decided that delaying this case for 30 days or more, for instance, would not cause a significant impact, or they feel like wouldn't cause a significant impact, they will delay that. But those are not insignificant procedures, as was mentioned. These are procedures that frequently are going to result in delays in subsequent care. Potentially, these are procedures that are causing ongoing chronic disabilities and pain, and so it isn't insignificant that the delay of those procedures are occurring. That's a very significant event, and will likely subsequently need to be accommodated. So in some ways, we're pushing the ball down the road with the idea that we hope to have some capacity to be able to accommodate those patients soon. But it is a little bit of a gamble. And so, but that has been occurring for weeks.
And Steve McCarran, to your question, what percentage of hospitals are postponing? I think every hospital that does surgical procedures that result in an inpatient stay is every day looking at who's on their coming surgical schedule and making choices about who to postpone and who to cancel. But I think my sense, Mark, is it's 100% of hospitals that do that.
I would agree. At this point, I've heard nobody that is continued to do planned procedures that are requiring an inpatient bed. We have very few tools, very few levers to pull in hospitals that can manage overall census. That is one, and it's certainly what I would describe as the last lever that we try to pull because it is such a significant impact. But this is the place that hospitals have found themselves, and again, leveraging the capacity that exists in all of the state's hospitals, including rural and critical access hospitals, is important. But it doesn't provide enough, and so we have to do something to hopefully to reduce overall the numbers of patients coming in, things like vaccines, and are really our only strategy at this point in reducing. One of the other only strategies in number of patients coming in are reducing planned procedures, but then on the other side, moving people out of the facility to the degree possible also becomes extremely important, so that discharge to a more appropriate long-term care facility becomes critical.
This is George. May I comment also?
Yes.
So we need to be clear about the fact that 90 to 95% of COVID admissions are preventable. In my hospital, we've seen a dramatic rise in the census, and the people that are choosing not to be vaccinated are affecting the people that need these procedures, right? They're occupying beds that shouldn't have to be occupied. And because of that, the bed that's needed for the person that needs to have a tumor removed or some other important procedure has to be postponed. And so those choices are affecting other people directly.
And to be clear, people who are saying no to vaccines, thinking that not trusting their physicians' advice about getting a vaccine, they are not saying no to hospital care when they're really sick. They are coming to the hospital and expecting the care, and that's really, really frustrating for caregivers to be like, this is now a preventable disease. Let's prevent it. On that note, I think we are at time. Thank you so much for joining us. We'll plan to do another media briefing probably in another week or 10 days, probably back to our regular Monday schedule. Unfortunately, we had hoped to end these. We hope there was not, as I said at the beginning, we hope there would not be COVID news to share, but it looks like there's going to still be. Please urge your readers, listeners, viewers to do everything they can to relieve the pressure on hospitals and keep themselves safe. They do not want these diseases. They don't want this disease. Take care.